So this lecture is going to cover parts of the cardiac conduction system. Before we can really start talking about dysrhythmias, which are presented in chapter 34, and that's where you're going to find most of the material that I cover in this Camtasia, we need to talk about the conduction system. You probably remember the conduction system from A&P, but I know for some of us it's been a while since we've had A&P, so I always like to do a little review. Remember that electrical impulses, they're caused by pacemaker cells. These pacemaker cells are located in the heart. What happens is they transmit electrical activity to other cardiac cells. The dominant pacemaker of the heart is the SA node. This is where the impulse actually originates. And so when you're looking at the SA node, when it originates, when it conducts those electrical impulses, it's going to originate at a rate of 60 to 100 beats per minute. So your SA node is your dominant pacemaker of the heart. After it goes to your SA node, right over here in this little picture, then it goes to your AV node. Once it's in the AV node, it just holds the impulse for a very short period of time, and then it sends it on through the ventricles. So when you're looking at rates in the AV node, your rate now is going to be 60 to 40 beats per minute. And then the last part of the conduction system is right down here, and it's your bundle branch system, and so that's your Purkinje fibers and your bundles of His. That completes conduction. But what I want you to look at is look at your rate right here, 40 to 20. So remember that your normal heart rate is 60 to 100 beats per minute. And so when you start getting in the 20s and 40s, realize that your person is not going to be doing too hot right here. You have to worry about decreased cardiac output. So this right here is your conduction system. It goes SA node to AV node to bundle branch system. So that right there is the conduction system of the heart. As I told you, your SA node, that is your dominant pacemaker, but the neat thing about our heart is we have backups. So if, for say, whatever reason, your SA node doesn't work, then you have an AV node that can take over, or you even have to have a bundle branch system. But what you have to look at is when it's not originating in the SA node, look at what your rate will be right here. Okay, 60 to 40. If it's 60, your person probably is not having any type of signs of cardiac compromise, but realize as the rate drops, your person's signs and symptoms of cardiac compromise become higher. So just be aware of that. So one thing that we need to talk about is EKG paper. Don't let the terminology confuse you. Some people say EKG, some people say ECG. They are the same thing. Typically, if someone says EKG, it's because they've been a nurse for a little while, and that used to be the going terminology. But the neat thing about an EKG, it actually provides a graphic representation, a picture really, of what the heart's electrical activity is doing at that time. And so it's really, really neat. It lets us look at the electrical conduction system of the heart. So some things you want to remember when you are obtaining an EKG is you want to make sure that your patient is laying in a semi-reclined position, that they're breathing normally, and that you don't place any type of electrodes over any type of irritated or scar tissue, because that could make the reading not be as accurate. Also realize there's lots of different types of EKG. You have a 6-lead, you have a 12-lead EKG. All of those leads are put on different parts of the body, and it lets us look at different representations of the heart, or different views of the heart per se. So some things we can tell just by looking at an EKG, we can see where is the heart in orientation of the chest. We can also figure out, do they have any type of ischemia, or do they have any type of electrical issues going on. We can look at what's their electrolytes from this, any type of conduction disturbances, so we can get a lot of information from an EKG. So as I told you, there's multiple leads. For this class purposes, what I need you to realize is we want to read an EKG in lead 2. So once you get done with this, I want you to go find an EKG on the internet and look at the paper. The paper has, you have to have EKG paper, and EKG paper is just lined paper. And those lines, they mean different things to us. And I'm going to go into that in just probably about 2 more slides. But On the sides of the EKG paper, they have Roman numerals. Depending on how many leads you have, it has different numbers. So you want to go to Roman numeral 2 and look at it. That's the lead we want to look at because that tells us that gives us the biggest overall picture of the heart's conduction system and what's going on. So if there are specific areas we want to look at, you'll see your healthcare provider say, well, I want to look at lead 3 or lead 4 because that shows different areas of the heart. But for this class, remember, my goal is that you learn to recognize all the parts of an EKG and you start recognizing strips. Okay, so I want you to always read everything in lead 2. As I told you, this is a great example of EKG paper. It's lined. It's made up of boxes, and these boxes some of them have darker lines. They have lighter lines inside of them. This right here is just pink, but some of your EKG paper is gray and black. It just kind of depends. But really what I wanted you to realize is that EKG paper, you have to have it when you're reading an EKG because these little boxes, they're significant for us. When you are reading EKG paper, remember each one of these little boxes. So this right here, I always like to, don't get confused with my picture here, but this is the overall EKG paper right here, okay? And I just had them take one of these little boxes and then one of these. I took out and then I took it out again just so you can see how small they are. So every one of the little boxes, so this box right here would equate to just one of these tiny little boxes right here, is 1 millimeter wide by 1 millimeter high. So when you're reading, you have two things we look at. We look at horizontal and we look at vertical axis. So your horizontal is what we're going to look at the most in this class. You get more into the vertical when you get into 203, which is a little bit more advanced cardiac. But horizontal axis, that equals time for us. Each one of these little boxes, it means something. So I told you this little box right here is 1 millimeter by 1 millimeter. So we equate that to time. So each one of these tiny little boxes up here, it's 0.04 seconds. Okay? And that's important to us because you're going to see as we start reading them why we need to know times. So we state our times in seconds. So what happens is each one of these, so this comes out, so each one of these larger boxes, okay, because see this picture right here, we just kind of broke this down. So each one of these boxes, they're 0.20 seconds, okay. And then just to kind of make it easier for you, 5 large boxes is 1 second. 15 large boxes is 3 seconds, and 30 large boxes is 6 seconds. And you're like, well, why do I need to know that? Okay, so remember I've just told you that when you read an EKG, you are going to read it in lead 2. The other thing you need to realize is when we try and see what's going on, the overall picture of the conduction system, we need at least a 6-second strip. Okay, so that's why you need to be able to pick out 30 large boxes, 6-second strips. Okay, so that is why you need to know 15 large boxes is 3 seconds, 30 large boxes is 6 seconds. Now the neat thing is most of your EKG paper now, they have hash marks. And these hash marks are really neat because they specifically tell you a 3-second interval. And so then you would just go from hashtag to hashtag to hashtag and you would have 6 seconds and you'd be able to read it on there. For testing purposes, any strip that I give you, it is safe to assume it is a 6-second strip, okay? Because remember guys, I'm just introducing you to EKGs. And so that's what I want you to get in your head is that 30 large boxes is 6 seconds. So what I like to do before I start trying to talk about all the different dysrhythmias, I take apart the cardiac cycle. We talk about every single component and then we put it all together. So for some of y'all that are a little bit more advanced on the cardiac side, or let's say your telemetry techs or your RD LPNs and you know how to read an EKG, this might seem a like I'm breaking it down too much, but it just works really well when I start small and then I build up. So just bear with me for a little bit. But your P wave, that is the first wave in the cardiac cycle. Your PA wave actually represents the firing of the SA node. So remember, when the SA node fires, then you have atrial depolarization, meaning the heart contracts and it continues to spread the impulse throughout. So as you can see right here, this is the P wave, the first wave. So before I can talk to you about a P wave, I have to show you baseline. That's the first thing you want to realize when you're reading strips is what is baseline. So I have it nice and color coded here, but here is your EKG paper right here, and this right here is your baseline. Okay, it's the black area. And when it starts to deviate up or down from baseline, then that is the beginning of your P wave. So as you can see, when it starts to turn yellow, that is the beginning of your P wave. And as it progresses, you see how it returns back to baseline. Okay? So this is just a great representation of that. So this is your P wave. It is the first wave in the cardiac cycle. I always like to think about a P wave kind of like a little hilltop right here. Okay? A normal P wave, when you're looking at it, it should be smooth and round. So this is another example I have. So again, look right here. So you see baseline is where my little arrow is. Okay? I'm usually in front of the board doing this, so bear with me, but here's my little arrow. This is baseline. You see where it starts to come up right here where these little marks are? This is the beginning of my P. You follow it around, and then when it returns to baseline, guys, that is the end of my P. This whole thing right here, this is the P wave. So it begins right here, and it ends right here. This is the first wave in the cardiac cycle. So when you're looking at P waves, some things you need to make note of. Normal P waves are very smooth and rounded. Okay? They are upright in lead 2, so we remember I tell you for this class purposes, we are reading EKGs in lead 2. And it should be no more than 0.11 seconds in duration. So it should be no more than 2.5 boxes. So when you look right here and you measure from here to here, you see that's about 2.5 boxes. Okay? Because there's 1, there's 2, there's a little piece of 1 right there, and there's a little piece of 1 right there. So this is a normal P wave. So if I'm going to tell you normal P waves, well then you know I got to throw some abnormals in there. So here's some great examples of abnormal P waves. This one right here, the first thing I want to put my arrow at is baseline. You got to be able to find baseline before you can find anything else here. So this right here is baseline. Okay? So where it starts to come up, this is the beginning of my P, and you just follow it around, and you see where it comes back down to baseline. That is the end of my P. This right here is a normal P. You see how it's smooth and round on each side, and it's no more than 2.5 boxes. This is normal. Okay, so let's look at this one right here. We all find baseline. Look right here and practice. This is your baseline right here. Well, it starts to go up, and we're going to follow it back down to baseline. But you see, as it goes up, you have this little notch here in the middle. It comes back, and then it goes back to baseline. This right here is what we call a notched P wave. Okay, so if you have notched P waves, that could be simply caused by an enlarged atria. So things that cause enlarged atria is just some examples I can just think of. COPD, congestive heart failure, any type of valve disease, they can cause notched P waves. So then we have a peaked P wave. Again, here is your baseline right here. It starts to come up, it peaks, and then it comes back down to baseline. This is a peaked. See how it's not normal because it's not smooth and rounded? So the causes of a peaked P wave are the same as they are for the notch. So it's usually due to some type of enlargement of the atria. Okay? And then you have inverted Ps. So inverted means instead of going up, it's going down. So again, let's look at baseline. My little arrow right here is on baseline. Okay, we follow it down and we go back around and come back to baseline, and it's inverted. So that right there tells us it's not normal. An inverted P wave, it's going down, meaning it's going below baseline, because this is baseline right here. Okay, and it returns right here. Anything below it is considered negative, or we call it negatively deflected, and anything that's above baseline, for example, like this would be above baseline, we call that positively deflected. So those are just some terminologies for you, but these are things that are abnormal P waves that you would need to investigate a little further if you were looking at someone's EKG and you saw these. So we talked about the P wave. The P wave is the first cycle, or I should say the first wave in the cardiac cycle. So let's move on to the Q wave. So your Q wave is the first negative or downward deflection that follows the P wave. We read and lead to, and it should always be negative, meaning going below baseline. When you look at your Q wave, what it's representing is just depolarization of the septum. That is what it's representing. So let's look right here. I have another little picture, okay? So let's practice baseline, because the only way you're going to learn EKGs is you just have to practice. So right here, this is baseline. I think we all agree we're good with baseline. Where it starts to come up, this is your P. It comes to a peak, and then it comes back down. So no, this is not a normal P, because remember, it's peaked. It's not smooth. But your P comes back down, and when it goes below baseline, right here, that is your Q wave, guys. Okay, where it goes below baseline, this is your Q wave. Okay, so following your Q wave, you have your R wave. So when you're looking at your R wave, remember, it's the first positive deflection that follows the P wave. So let's look right here. Let's start over again, okay, because we definitely need to practice. This is baseline. This is where it starts to come up, and so this is the beginning of your P. Okay, you keep following your P. You see how it's going back to baseline right here? Okay, so it's back at baseline right where my little arrow is. It's at, oh, my arrow just disappeared. Okay, it's baseline right here. Okay, and then you see where it starts to go downward, because remember, your Q wave is your first negative deflection, meaning it's going to be below baseline. So if baseline is right here, then this right here is your Q, where it shows it. Okay, so then what you're going to see is you're going to have a positive deflection. So this positive deflection, this is your R wave. Okay, and R waves typically, guys, when you're looking at EKGs, they're pretty easy to pick out, because they're usually the tallest wave in the cardiac cycle. So they are pretty easy to follow out. So you just look at your R wave, and then it's going to come back down to baseline, and then we're going to follow it up with an S wave. Okay, so your S wave is the negative waveform that follows the R. So again, let's practice. This is our P. This is the beginning of our P. Here is our P. Our P comes back to baseline right here. Okay, follow it over. This is baseline. Up, you see where it starts to come down? Well, that right there, that is the beginning of your Q. And then where it goes back to baseline, that starts your R. Okay, you follow it up. This whole thing right here is your R. Okay, so you follow it up, and then you see when it is at baseline, then what happens is it goes below baseline, and once it goes below baseline down here, this is your S. Okay. So the reason I take each one of those apart is because typically when you read it as a QRS. So let's practice on these. Remember, your QRSs follow normally a P wave. So baseline, here is your P wave. You see it goes up, it comes back down to baseline. Okay, you see where it starts to go below baseline. This is your Q. and then it comes up. This is your R, and then it goes back to baseline, and then when it goes below baseline, guys, that's your S. That is your QRS complex. And so when you're looking at your QRS complex, some things you need to realize is that a normal range for a QRS complex is 0.06 to 0.10 seconds. So it shouldn't be more than 3 small boxes. Okay. Remember that the QRS, it represents the spread of the electrical impulses through the atria. Okay. So the reason I always like to tell you that is when we're reading strips, if you're looking at your QRS and your QRS is abnormal, or it doesn't, something's not right with it, well then you know you got an issue somewhere in your ventricles. If you're looking at a strip and you look at these P waves and there's something going on with your P waves, remember I told you that P waves represent depolarization of the atria, then you know something's wrong with your atria. So that's just, I always like to throw that out there when you are reading strips. Those are 2 things that you really want to keep in mind. As I told you, your QRS, you have a Q, an R, and an S wave. Okay. So again, let's go back. I gave you normal, nice, pretty QRS. Okay, so I got to throw some abnormals in there. Okay, or it just wouldn't be nursing. So an abnormal QRS is anything that is less than 0.04, so less than 1 small box, or greater than 0.10. So that's so no more than 3 small boxes. So that's your range. If it is less than or greater than, then we consider it abnormal. And so that's what you want to realize when you see these. So abnormal QRSs, they let you know that something's going on in the ventricle, and so you would need to do a little bit further investigation here. So then let's talk about our T wave. So your T wave represents ventricular repolarization. So this is kind of where your heart is resting. It's getting ready to start going again. So this is where your heart is most vulnerable to any type of extra stimuli. So you got to be careful about that, guys. When you're looking at your T wave and you're wanting to figure out, well, where is my T wave? The best thing that you want to do is it follows your QRS, and it's a positive deflection following the return to baseline for your QRS. So look right here and let's go through the whole cycle again. This is baseline right here. Okay. You see where it starts to come up? This is the beginning of your P. Okay. It comes back to baseline right here. This is the end of your P. This is baseline, and you see where it starts to go down? That right there, that is the beginning of your Q. Okay. And so here is your Q. It starts to, here's baseline, it comes to baseline, and this is your R. Okay, when it goes below baseline, you're at your S, and then when it comes back over here, we're looking to where it goes back to baseline, and then your first positive deflection following that, where it starts coming up again, this right here is your T wave. Okay, so guys, all of this right here, this is the cardiac cycle. So remember, a normal T wave is slightly asymmetric. I like to think about T waves if you're comparing them, because I always have students say, well, my P waves and my T waves, I can't tell a difference. So 2 points that would help you with that. One, when you're looking at P waves, they should look like little hilltops. They should be symmetrical on each side, kind of nice and smooth and round. But your T waves, they're slightly asymmetrical, so I think about them as mountaintops. You're having to climb up one side to get to the top. So one side's going to look a little off than the other one. For example, here's some normals right here. These first ones that my arrows are circling right here. Okay, so this right here, this is your T, and then here is your P. So look at it. You see how it's slightly asymmetrical when it comes up? Same thing right here. It's slightly asymmetrical. Okay, so those are just my tips really for how do you tell a P wave from a T wave. The other thing is, remember, look at your QRS complex. This is your R. This is always the easiest thing to find is your R. Well, you know, if it's before the QRS complex, it's your P. If it's after, like right here where my arrow is, it's your T. So those are two tips to try and help you get it straight in your head. So we look at T waves a lot. If we have inverted T waves, like we see here, okay, these are inverted T waves. We are very concerned about that because that shows us, or that lets us know there's been some type of myocardial ischemia. Okay, so we get really worried about that, and the reason that is remember that your heart is made up of cells. Cells need oxygen to survive, and when someone has ischemia, they're not getting the oxygen they need to be able to function. So we worry about inverted ones. But then you know what? We don't really want these tall peaked ones that you see here also. When you see really tall peaked, remember it comes up to a point like this one right here. When you see these, then what I always want you to think about is, oh my goodness, what is their potassium level? Because typically you will see these in people that have very high potassium levels. So these are just some abnormals that you're going to come into contact with when you are in practice. I always like to make mention of a U wave. You probably will not see a U wave too often, and we don't know that much about U waves. We think, and I put it on here, we think it's actually the repolarization of some of the fibers in the heart, but we're not positive. What we do know is we see U waves most often in people that have a very slow rate, because they're easier to see because they're very small. As I told you, usually they're less than a third the size of a T wave. And so also realize some people have U waves and it doesn't mean anything. However, what you as a nurse should realize is that if you see a U wave, a lot of times it means that patient has low potassium level. And so what you would want to do is you would want to get an order to check their potassium level if they haven't had one recently, or you go look at their potassium level, let's say if they've had one that day, and see if it's within normal limits. So it's just kind of one of those, if you see one, you really need to go and look, and if you see one and it looks abnormal, it looks larger than your T wave, you really want to be thinking, what's this person's potassium level? Let me check it out. So that's why I always like to mention it, okay? So it's not always a tried and true, meaning that person's going to have electrolyte imbalances, but if you see one, it's always best to be safe, and let's look at their labs. Let's get something ordered. Here are some examples of U waves. So as you see right here, this is a really slow, it's real pretty, but it's a really slow rate. So these U waves are very easy to see, and I have them highlighted in red right here. So I always like to start at the top. So this right here, this is baseline, okay? This where it starts to come up, this is the beginning of your P. You follow it around till it comes back to baseline. That's the end of your P, guys, okay? And so, here, there we go. And so what you're going to do is you're going to, where it goes below baseline, that's the beginning of your Q right here. It comes back to baseline, and then it comes up. This is your R, guys. It stays your R until it comes back to baseline. Here's baseline, and then, uh-oh, look, it drops. Okay? So this is your S. And then what happens is it comes back to baseline right about here. Okay? So you follow it, and you see where it starts to go up. This is the beginning of your T wave, and it comes back to baseline. This is the end, and then, look, it's just this extra little wave you have right here that follows your T wave, okay? And this is called a U wave. So when you see a U wave, you better go check their potassium level and see what it is. So I talked about waves. Now I want to go back and pick up with some intervals. And I know this seems really overwhelming now, but it will make sense when I start to put everything together, and just realize you're not going to get this all at one time. So you need to take little breaks and come back and make sure that you understand this before you go forward, so that you don't mess yourself up and get confused. So a PR interval, it represents the beginning of the atrial depolarization to the beginning of the ventricular depolarization. So when we measure a PR interval, we measure it from the beginning of the P wave to the beginning of the QR complex. Okay, so I've highlighted it right here for you. So when you're looking right here, again, this is baseline. Okay, this right here, this is the beginning of the P. You follow it all the way around. Okay, you're back at baseline, guys. Now you keep following it, and when it goes below baseline, that right there is the beginning of your QRS complex. So this is what you would measure right here. Okay. So essentially what that's telling us, that PR interval is telling us how long it takes for the impulse to get from the atria to the ventricle. This PR interval is telling us that. Okay, it should be between 0.12 and 0.20, so no more than 5 small boxes. Some things that can cause a abnormal PR interval, if it's too long, it could be because they have something called a first-degree block, which we will learn about that shortly. Or they could have digitoxicity. That can also cause a prolonged PR interval. So I talked about PR interval. Let's talk about ST interval. So ST interval looks at, or I should say, it represents the end of the ventricular depolarization to the beginning of ventricular repolarization. So we measure a ST interval from the end of the S wave to the beginning of the T wave. Okay, your normal range should be no more than 0.04 seconds. Okay, so remember what 0.4 seconds is? Okay, it should be no more than 1 box. Okay, so when you're looking at this right here, the reason we look at the ST interval is because this ST interval, if it's abnormal, okay, meaning this ST interval, if it's elevated, meaning really up here, or if it's depressed, meaning less than or down below here, of greater than 2 millimeters, well, that tells us that that person has some type of myocardial ischemia and or injury. You see that often in people who are having or have had an MI. So that's one reason when someone comes in with chest pain, we always look at the ST segment and see kind of what's going on. So ST segment and then also your T wave, those are our 2 big ones that we look at when we suspect that someone's having an MI. Okay. So guys, this is everything we just covered. We covered the P, the QRS, the T. So let's kind of do a little recap and a little review. This is baseline, where it starts to come up. That's the beginning of your P. You follow it around till it comes down. That's the end of your P. Okay. Then what you want to look at right here, you follow your baseline. Your Q starts where it starts to deviate down, because remember your Q is negative. So it's negative here. And then here's baseline. When it starts to come up, see where it's starting to come up? This is your R right here. Okay? And then when it deviates down below baseline, that's your S. And then it comes back to baseline here. Baseline. And then when it starts to come up, this is the beginning of your T. And when it returns to baseline, that is the end of your T. So, guys, this is kind of everything we just covered. And so you need to go back and review, again, that chapter in your book that talks about cardiac dysrhythmias. It goes into each one of these and it breaks it down. So that's a great resource for y'all to use for this section.